Okay. Number 10. Number 11. Number 12. All right, number 13. Almost one of those nothing differentials. Number 14. Here's a differential that goes along with this one. Number 15. Number 16. Right, and number 17. Sorry, there's a big air bubble there. We'll still be able to see it. Sorry, trying to focus here.
Yeah, just kind of.
And this one's a little bit tough to focus because this big wood splinter. It's just thick. All right. All right. Are we on 17? 18 maybe? I lose track. Yeah, we're on 18. Yep. Because she took one. Everybody still able to hear me okay? Okay, just double checking. Thanks. Number 19. Okay, we're on number 20. Okay, I think we'll leave it at 20. We could do extras after we go through these if we have more time. So I will start on the first one, and you guys are we'll do more after this. I'll start on the first one here, and then if you can either speak up and I can hear you, or type it in if you can't speak into it. Hey guys, thoughts on the first one? Don't be afraid to just blurt it out. So this is number 1. Anyone on this one? Nobody?
We were just discussing over here about a halo nevus.
Yeah, that's right. Yep. And that's what that is. So so as you look here, you'll see some what I was honing in on earlier. These are melanocytes. These are nevus cells right here. They're relatively small, round, uniform. You know, it's overall the nevus cells are pretty much in the upper papillary dermis or in the papillary dermis, and then underneath the nevus cells, there's this band of lymphocytic inflammation. So yeah, this is a halo nevus. So nevus cells and lichenoid, pretty much sort of band of lymphocytes. So this is halo nevus. All right, we'll go to the second one. You might have a differential along with this one. Anybody have any thoughts on this one?
We were struggling a little bit on this one.
Yep.
Throughout MF.
Yep.
Although it's not quite as much vacuolar interface as we would like for that.
Mm-hmm. Okay.
We talked about, what did you say? I even thought about coat sleeving. Like
okay. Yep.
You're kind of holding things.
This is a little bit tougher one, and it's a little bit subtle-ish, kind of. So, but I would say that we do have a little bit of an interface. Like you see some basal vacuolization right here, and but I'll take you sort of through the main hallmarks of this. So we got kind of a plate of parakeratosis. There is some lymphocyte exocytosis, so that's where, although this wasn't that, that's where the thought of MF came up from a few of you. But then we've got a little bit of an interface change. So there's some vacuolization. There's a little bit of rare necrotic keratinocyte. Let me see my arrow, get my arrow going here. There's a little rare necrotic keratinocyte, but not a ton of them. And then this superficial lymphocytic infiltrate. And I guess if I had the perfect case, I would like to have a few maybe extravasated reds. So this was actually a case, and we also knew the clinical on this one, which is important to know, but this was Pityriasis lichenoides chronica, PLC. If we wanted this to be, say, pleva, then I would, sort of magnify a lot of the things I just said, such as maybe more lymphocyte exocytosis, more necrotic and more obvious necrotic keratinocytes, because that correlates with the clinical ulceration of the lesions. And then I would like some more inflammation actually as well. So this fits more into a Pityriasis lichenoides chronica. Interface dermatitis, I mean, we have a big differential for that. Erythema multiforme is an interface dermatitis, but I don't like the stratum corneum for EM because this has some chronicity to it. Usually with EM, you have sort of a normal basket weave. And then connective tissue disorders, we'd like some mucin. If it's really like lupus erythematosus or dermatomyositis, rather than this plate of parakeratosis, we'd see maybe some hyperkeratosis, maybe compact. So it fits most with that. Somebody mentioned Pityriasis rosea. It is a little bit of a mounding of the parakeratosis, but this sort of interface process is not typical for Pityriasis rosea, although rarely you can have some interface in some atypical PR cases. All right, cool. You guys are ready? We'll go on to the next one. All right, how about on this one?
We said angioleiomyoma.
Angioleiomyoma, that's right, yep. And that's been typed in from OSU as well. So yeah, this is a nice classic example of angioleiomyoma. You have this basically ball of tissue comprised of really, you can just break it down, two things. Angio, which is vessels, and leioma, which is smooth muscle. So, and it's a very compact, there's sort of no normal stroma in between. It takes over the whole area. And all these little circular areas here are all little vessels. And then you can see more of kind of a typical fascicle of muscle right here. So together that's angioleiomyoma. There's not too much else that we see really that looks like this for a differential. Okay. Next one. All right, how do you guys feel about this one?
Said NLD.
NLD? Good. Somebody had mentioned lupus paniculitis on the screen here, but all this pathology in the dermis wouldn't necessarily fit with that. But I would say, though, if you just had some of the changes down here with all these lymphocytes, and I don't know if there's so much hyaline necrosis we can really see, then you might think of lupus paniculitis. But then the main thing, though, in the dermis here, these broad bands of sort of pale acellular collagen with these sort of tiers of inflammation. And this one shows that you can have a lot of histiocytic multinucleated giant cells within NLD, such as here. This had a lot. But yeah, just these broad tiers. Even on low power, you see anything like this, it's one of the first things you'll want to think of. All right, NLD. And then this one here, I think I kind of honed you guys into a couple of areas. I don't know if that helped or not, but let's see. This is one of the areas I took you into. You guys have any ideas for that?
Macular amyloid?
Macular, is that what you said, macular amyloidosis?
Yeah.
Yep, that's what that is. So these sort of pale, sort of mini nodules of amyloid material. Let me see if I find another one here. Yeah, here's actually a little aggregate of it right here. That little collection of material is amyloid. Let me make sure I get that in focus here. Sorry. Yeah, right here. Brighten it up a little. Right there. So this is amyloid. So this is macular amyloidosis, as opposed to lichen amyloidosis, where we would see more hyperkeratosis, more epidermal hyperplasia. This is generally pretty thin epidermis and with just amyloid deposition. So this is macular amyloidosis. Right. What genetic issue, what gene could this patient have an issue with?
P10.
P10, all right, good. Board test, board exam question. Yeah, so this is a circumscribed storiform collagenoma. That's one name for it. So derm's kind of goofy with all their nomenclature. So the other name for this is sclerotic fibroma. And if you see a bunch of these things, you can see them in patients with Cowden syndrome that have a P10 mutation. So this is really just a classic case. Nothing else looks like this. Sort of like the Angioleiomyoma. Not too much else looks like that, and nothing much else looks like this. All right. Okay, so we're on number 7 of the unknowns. So we'll just go to this one here. Anybody have any thoughts on this here? What's this material? Calcium. Yep, somebody typed calcium, and that's what all that is. Purple stuff. It's just all deposits of calcium. And when we see calcium in the skin, you know, that's sort of a general thing. We generally call it calcinosis cutis. Of course, when we do see calcium, there's a lot of different reasons, you know, that it could be there, and specific entities that could cause that. In this particular case, there's an entity that occurs mostly in, you know, young kids, maybe teenagers, where primarily in the head and neck area, they get a random deposit of this calcium. And somebody, OSU typed it in, that's correct. It's a subepidermal calcified nodule. So that's a known, you know, clinical entity that shows calcinosis cutis. So subepidermal calcified nodule. In every case I've seen of this, really like what you see here, where the epidermis is hyperplastic and the calcium is just sort of pushing into the dermal papillae, it kind of has that pattern most of the time, big sheets of it. We didn't look at this case here, but I'll just show you a case I saw recently a couple of weeks ago, and this was a biopsy from the penis, and we have all these deposits of calcium. So another type of situation, and I don't think I had seen this before. So the entity they sort of call is idiopathic calcinosis cutis of the penis. And so here's just another. And then of course there's scrotal calcinosis. Okay, we'll go to the next one. If you guys are ready.
You said gout?
Yep, that's right. Yep, gout. Everyone's right. You get these sort of deposits of pale, sort of pink crystalline material with inflammation surrounding it. And the inflammation here you can see is some multinucleated giant cells. So it's almost like a foreign body. It is a foreign body reaction to the material in gout. So it's good. Typical case of gout. All right. Anybody have any thoughts on this one, the next one? At some point I might fall out of order, so just tell me if I'm out of order. Yep. Ulceration, crust, and then what's all that stuff down there?
We also said calciphylaxis.
Yeah, calciphylaxis. And so we have ulceration, and presumably some epidermal necrosis might have preceded this. Just inflammation, fibrosis everywhere. It's just kind of a messy picture, but these deposits of calcium. And of course, this one came with the nice history of a the calcium phosphorus product elevated, renal failure, painful purpuric plaques. So this is calciphylaxis. We have to be a little careful when we sign these out to make sure the clinical, I can't just look at this and just automatically say calciphylaxis, because this one's a little bit more obvious, but you'll have some where you get some calcification in some vessels, like for instance when a squamous cell is excised from an old person's leg, and you can get some sort of incidental calcification in vessels at times just from advanced age rather than in the context of calciphylaxis. They call that Monkeberg sclerosis or medial calcific stenosis in those instances. All right, how about this one?
SPAP?
SPEP? Somebody said SPEP for $200. That's Jeopardy. Yes, this is SPEP. So you can see a transition from the normal skin here into the lining, apocrine lining, and then also we've got these papillary folds right here. And I think earlier I showed you, and I'll show you again here, plasma cells. Let me brighten that up. And there are several plasma cells with the eccentric nucleus and pale perinuclear area. So this is just a real nice Syringocystadenoma papilliferum.
That was on our in-service exam this year, and they gave us a really zoomed up close-up picture like that where you didn't see the overall architecture.
Okay.
You just knew about the plasma cells, and they gave us HPAP and SPAP as choices.
Oh, did they really? Okay. Yep.
Good to see, to go up close and actually hone in on those.
Yeah. So
that's what they gave us.
They just want to mess with you, I guess. So yeah. So yeah, they just did something like this then. Okay. Was that the exam like just at your institution, or was this like the nationwide in-service?
The nationwide.
Okay. Okay.
They
Yep.
had it similar to that.
All right. Okay, good. Good example of that. Okay. I'll go on a little higher power for this.
You said mastocytoma?
Yep, that is exactly right. So, and on low power, even I think you can start to appreciate, or as we go a little bit high, that the cells are just they're kind of just bland and monotonous. And we know that the mast cells, they sort of the nucleus sits in the middle, and the cytoplasm sort of sits around, like an egg kind of. So the cells kind of are spaced out nice and evenly and sort of orderly. And that's what we see here. So it's loaded with mast cells. Any stains that you guys can recall that you could do if you'd wanted to? There's a that's right, CD117, which is the C kit. Yeah, that's tryptase. There's also toluidine blue you can do. There's probably half a dozen different stains, but yep. So that's good. All right, urticaria pigmentosa or mastocytoma. And how about this one?
Trichoepithelioma.
That's right. Yep. And not a trichoblastoma, although there's different subtypes of trichoblastoma. This is small, and it's got really just this reticulated basaloid lobule pattern within a fibrotic stroma. And I guess if we had the perfect triad, we'd like some horn cysts. But so that's kind of the triad. So reticulated, you can see that these basaloid lobules are reticulated. So reticulated basaloid lobules, fibrotic stroma, and I'll go into a little higher power on that, rather than the retraction artifact and the mucinous stroma you can see with basal cells. This is all fibroblastic and fibrotic, and horn cyst would be the other triad. Okay, trichoepithelioma. And then I kind of zoomed you into the main area right here. What do you guys think about this one? Yeah, it was typed in Tinea nigra. And it's known that the Tinea nigra can sometimes create these sort of space, low power, all these sort of I can't remember the mechanism for that, but it does something where it can create these sort of spaces. But then you have this really dark, pigmented fungal organisms here. So this is Tinea nigra. We can see it's acral, so this is usually on the feet, sometimes the hands. Go to the next one. All right, here. This has kind of a differential. So this could be many different things. Anybody have any thoughts on what might be on the differential for this? Yeah, somebody said the pigmented SK. That's definitely on the differential. The other thing you could theoretically put on here is, yeah, somebody said condyloma. We want some corticolytic change on it for that, but the overall architecture could be with that acanthosis nigricans. So that's another thing that fits nicely with that. Confluent and reticulated papillomatosis can sometimes give you this. And then what this one was actually was a linear lesion on a young kid. So this is an epidermal nevus. You can kind of see if we were to, some of you might have heard me give this example, but it's kind of just undulating up and down, almost like a roller coaster that's sort of going up and down. You could draw a line following the stratum corneum with its dips up, and you kind of get that picture with an epidermal nevus. But again, the differential SK, epidermal nevus, acanthosis nigricans, and CARP, confluent reticulated papillomatosis. Here is the next one, and anybody have any thoughts on this one? A little subtle. So
yeah, is this a follicular plug?
Yeah, there's it is a little bit of plug right there, sort of, but mostly, you got this little hyperkeratosis, and it's a little papillomatous. You see this, that epidermal nevus we just saw? You see how it kind of is papillomatous? Just slightly right here as well. It's just kind of subtle. And so this is sort of a somewhat similar differential to the one we just saw, but just less pronounced than the other one. And this person, we had a history submitted as these brown velvety patches that were kind of reticulated on the chest and the back. So this one is actually confluent and reticulated papillomatosis. I mean, without knowing any clinical, I would still keep acanthosis nigricans. Epidermal nevus, I suppose, would be a really subtle one. And even if you get out here, and if they just said, hey, it's a macular SK, that could still be on the differential. But this one happened to be CARP. this is where I may be out of order. So is this what you guys have next on your list?
Wood splinter.
Yep. Yep. There you go. Perfect. And I was going a little bit higher power. There are some fungal organisms. I was having trouble focusing that a little bit, but let me turn this. You see this right here? And actually, we have a lot of little fungulars, and here's another one right here, here, right in here. So this person got a splinter, and it was contaminated. And this is usually Dermatopathology fungi, and this is usually in the family of after my memory here, Phyochromomycosis or chromomycosis. And it's just a secondary kind of thing that can come along with the wood splinter. So I happen to actually see this patient myself, and so I didn't treat her for any antifungal treatment or anything. I just saw her back in a few weeks, completely clinically resolved, so I didn't do anything else with it. So it's pyohyphomycosis. All right. What do you guys think about this? We've got typed in from 2 places there, Osteoma cutis, which is exactly correct. And the main thing, this is all purple, so this is sort of calcified bone. This orange, kind of eosinophilic sort of periphery is really the heart of kind of the bone tissue. So that's a classic picture of that. And right here, even more so, the orange is kind of taken over. And let me show another example that we didn't look at, but sometimes it's a little more tough to make out because this all looks like it's calcification, but then just at the edge, you can kind of see this sort of orange periphery. You see right around there. So this is bone, and this is sort of the fatty bone marrow sort of being present even in the Osteoma cutis right here. And then another case of Osteoma cutis. Smashed a little bit, but you can see that orange periphery right here with the calcification. So, all right, getting there. Anybody have any ideas on this one?
We were trying to decide if this was sebaceous. We couldn't quite tell if those
Kind of
sebaceous.
had a little bit of a, yeah, this is, let me just go into here. So the cells are clear, right? But they don't have that sort of same vacuolization or sort of foaminess that that sebaceous cells have. So the cytoplasm is actually pretty clear and pretty open. And and sort of it's also admixed. So you got sebaceous gland mixed with more typical epithelial cells. So this actually it doesn't fall into a sebaceous category. We've got a predominance, I would say, somewhat predominance of the clear cells and these large sort of nodular aggregates of tissue. So this is actually a Hidradenoma. And if we look carefully, we should be able to find some ductal areas right down in here. So this is a Hidradenoma. I probably would actually subcategorize this as a clear cell Hidradenoma because the clear cells kind of tend to predominate in this one. So if let me go into higher power, see the clear cells there. If these other cells here kind of predominated, and took over. I'd probably more call that a nodular hidradenoma. Or if we had this predominating, but a lot of cystic spaces, larger cystic spaces, we would then call that a solid cystic hidradenoma. Yeah, these just aren't sebacites. I know, you guys. Hopefully you trust me. Okay, and then we will go to a couple more here.
I think this was a JXG.
Well, for JXG, we want that classic two-ton giant cell, which, let me see if I think I randomly have one sitting here. Let me just see if I can pull that up. Yeah. So this is a JXG, since you mentioned it. And here is what you get, this classic two-ton giant cell. And just to clarify, central large cytoplasm with a peripheral rim of nuclei with even more peripheral vacuolization around the periphery here. And JXGs, this is a JXG right here, they're sort of large and nodular and kind of deep, you know. So go back to the case that we did as an unknown, and you know, you might get that feel on low power, and yeah, we'll say it's shaved so you can't really tell. These are more, it's starting to maybe make you think that there's a little vacuolated periphery, but these are similar in that you've got this central here with the rimming of the nuclei, but here you've got some where the nuclei are sort of just mixed up and not sort of in that pattern. And then I got to give it to you on some of those. They kind of do look like two-ton giants. I'm talking like I'm so smart, but some of them do look like that. But the other thing is in the background of prominent solar elastosis. And if we look carefully, oh, was that? Yep, that's right. Somebody just typed it in here. So you have prominent solar elastosis, granulomatous inflammation with some giant cells. And if we look carefully enough, we might find elastophagocytosis. Let me see if I can find that for us. And so the diagnosis is annular elastolytic giant cell granuloma. And this probably actually, let me see if I can find it. Sometimes you'll see these giant cells that have sort of, I would say almost like ingested these bands of, residual bands of elastosis here, of elastotic material. So annular elastolytic giant cell granuloma. It's thought to be some kind of GA due to chronic solar exposure. And I think we might be on our last one here. All right.
Desmoplastic trichoelomoma.
Yeah, that's perfect. Yep, desmoplastic trichoelomoma. So the overall architecture you'll see is this sort of hyperplastic, endophytic, kind of bulbous cells with kind of pale cells, which are pretty typical. So trichoelomoma, this is the kind of typical cell that you see here, these sort of pale clear cells. And as you noted, with the addition, though, of these areas of sclerosis within it that we have here. So we'll see a lot of trichoelomomas that we just call trichoelomoma. They have a little subtle focus of sclerosis. But in this one, I would say the sclerosis kind of takes over the whole central part of this tumor, so that, yes, we would then classify this as a desmoplastic trichoelomoma.